We're very excited to be here as a team of clinicians who work together every day to take care of women with breast cancer, to present some innovations in breast cancer care from each of our separate disciplines, and to have a multidisciplinary discussion amongst us as a team. Hopefully you'll be ready with some great questions that we can answer for you, and to introduce you to more of the work that we do here in the Bridgeport area in the Norma Frein Breast Center, in the Smilow Cancer Center. My name is Dr. Melanie Lynch. I am a surgical oncologist and the medical director of the Norma Frein Breast Center. And I'll be the moderator tonight as we get to kind of celebrate the work of my really smart colleagues, as we talk about each of the separate disciplines involved in breast cancer care. We're very excited tonight to introduce all of you to the newest member of our team, Dr. Monica Valero. I said one of the best things about being middle-aged is all of the bright, smart, young surgeons and physicians that I get to learn from every day. And we're very excited that Dr. Valero has joined our team. She's an assistant professor of surgery at the Yale Cancer Center and Smilow Cancer Hospital. She'll be caring for patients in our cancer center in Trumbull and here in Fairfield and Bridgeport Hospital. She is the director of the Hispanic Breast Center program. Prior to joining Yale, Dr. Valero was an assistant professor of surgery at Beth Israel Deaconess Medical Center, where she was also the director of the Hispanic Breast Cancer program. She trained both in Boston at Massachusetts General Hospital and at Memorial Sloan Kettering, where she did her breast surgery fellowship. So welcome, Dr. Valero, and we're excited to hear about innovations in breast surgery.
Thank you, Dr. Lynch, for that warm welcoming. I'm going to share my screen now. So, okay. Good evening, everyone, and thank you for having me here. I'm very excited to be talking with you tonight, and I'm going to be talking about the updates in breast cancer surgery and the de-escalation of care in breast cancer treatment, and I have nothing to disclose. So breast cancer surgery has evolved significantly in the past 20 years, since the early 1900s, when William Halsted described the radical mastectomy, and it was not until the 1960s or 1980s when the term breast conservation came. We were aware of the term breast conservation when John Madden and Bernard Fisher described it. However, before then, all women with breast cancer, independently of the stage or age, underwent a radical mastectomy, and this was a very significant surgery that had a very high risk for lymphedema, high morbidity, and mortality. However, since then, many things has improved and has changed thanks to the Milan trial and the NSABP 04 and 06. We know we stopped performing radical mastectomy when breast conservation proved to be equally effective. We have also reduced the number of axillary lymph node dissection that we perform in lieu of the sentinel lymph node biopsy, first in the sentinel lymph node negative patients, and most recently in the clinically node positive patients. Thank you to the CLGB43, we also learned that we can avoid radiation therapy in the older population, those 70 or older that have hormone receptor positive. The Taylor trial also was the systematic therapy decisions are now routinely guided by tumor biology, and result of this trial, the Taylor X, which is using the 21 gene expression to assess the risk of cancer recurrence in women with no negative hormone positive invasive cancer. This allows women to spare necessary chemotherapy when the test or the oncotype has shown to be in a low range. And for women with non-invasive breast cancer, the COMET trial is actively evaluating the safety of active surveillance versus a standard local regional treatment. So overwhelmingly, the breast oncology community has led efforts in cancer care to align patient-centered care with best practice, and many of this effort has been led by surgeons. But let's jump into a breast imaging. So imaging for screening is used to detect cancer in asymptomatic patients. Therefore, routine screening mammograms are recommended, and we know these have reduced breast cancer mortality by over 30%. As we can see here in the slides on the left, we have a mammogram picture showing a spiculated lesion. And on the right, we have at the top of the right corner, we have a mass-forming lesion, most likely shown by ultrasound, and on the bottom, some calcification. So some of these lesions, or most likely the early stage breast cancer, are appear as a non-palpable, and this is the beauty of the mammogram that allows to capture this lesion in an early stage or before they are palpable. So there are many guidelines in terms of breast cancer screening, and there have been recent updates and in terms of when women should start and when should they stop. If we look at the American Cancer Society guidelines, we can see that they recommend women to start getting mammograms every year at the age of 45 up to 54. For women younger than that, starting at 40, they recommend women to have the choice to start annual breast cancer screening at that age. However, for women 40 and 44, those who has a lifetime risk of developing breast cancer in the future that is 15% or higher, they can have the recommendation to start at the age of 40. And then after 55, they recommend to switch to mammograms every 2 years, or they can elect to continue yearly screening. But on the other hand, we have the American Society of Breast Cancer Surgeons. They have this official statement where they actually recommend that women should start with yearly screening at the age of 40. In those younger or older than 25, undergo formal risk assessment of breast cancer. And this is for the overall population. For those women with a higher than average risk, they recommend to continue with yearly mammograms, but also to offer a yearly supplemental imaging, which is usually MRI. And then again, stopping mammograms when the life expectancy is less than 10 years. So updated guidelines from the American Society of Breast Surgeons also recommend the use of 3D mammography for women with a history of breast cancer and inclusion of breast MRI for those high-risk women, usually high with lifetime risk higher than 20%, for those with dense tissue or those diagnosed under the age of 50, and when recommended for the physician as well. Now jumping into breast cancer surgery. So when breast cancer is diagnosed, there are two surgeries that can be performed. One is breast conserving surgery, and the other is mastectomy. Both long-term and contemporary data have consistently shown that these treatment options are equally effective, leading to comparable local recurrence rates and equivalent disease-specific and overall survival. Meaning the chances of having a recurrence or the chances of dying from the disease is not going to change based on the surgery that you elect or that the patient undergoes, and it's not going to be impacted by that. Breast conservation. So breast conservation, or also known as lumpectomy and radiation, is defined as the surgical excision of the primary tumor with a margin free of disease followed by whole breast radiation. The margins need to be free or clear of disease to most effectively reduce the risk of local recurrence. In order, when patients undergo these procedures, they have to understand that there's going to be an incision in the breast, that there can be changes in the size of the breast, that we will need a localization technique in order to identify these lesions, because in the majority of them, they're small and non-palpable. And some of them can also elect for oncoplastic techniques if they want to have some reconstruction or to match the size of the breast. As I mentioned, these lesions are usually small or non-palpable, so there is no way for a surgeon to identify the area that we're going to remove with a naked eye, and we'll need preoperative localization techniques. The most commonly known, the wire guide localization, which has been the mainstay for localization technique. However, this technique requires patients to arrive prior to the surgery to undergo to the radiation department and have the wire placed. So it has restrictive scheduling requirements and can cause a lot of patient discomfort. But most recently, and over here at our Smilow centers, we use a radiation-free wireless localization technique. Using a tag or device, which again is placed in the radiology department. It can be placed few days before the surgery. And again, the intention is to guide the surgeon to remove the lesion or the accurate lesion. These modern alternatives have proven to be effective and time efficient alternative to the wire guide localization. They have low margin positivity and reoperation rates. They have high patient, radiologist, and surgeon acceptance. And they also allow for a smaller resection and improve patient comfort satisfaction. So it's very convenient. But talking about margins and what we have to remove. Surgery is intended to remove what we know by imaging or by preoperative exam, what is in the breast. We know that up to 1/3 of women's, or one out of 3 women will have additional microscopic disease that is not captured in preoperative imaging or physical exam. Therefore, obtaining negative margins remains challenging, and reoperation rates are considerable, ranging from 15% to 40% nationwide. So additional surgical procedures have the potential for added discomfort, surgical complication, compromised cosmetic outcomes, and additional unnecessary stress for patients and family, and also increase the health care cost. So the Society of Surgical Oncology and the ASTRO consensus guideline is a consensus that was took place in 2013 and was published in 2014, and they created a panel of experts in the area, and they performed a meta-analysis of 33 studies that included more than 28,000 patients, and they concluded that positive margins increase the chances of breast recurrence by two times, concluding that no tumor on ink is considered a negative margin. Again, age, histology, size, and ASC did not impact these findings, which was very, very interesting. Soon after the consensus release, Dr. Chapgar here at Yale, she demonstrated that the reduction of margin positivity with the use of the cavity-shaped margins, which is now a standard of care. And this is basically consists in after the lumpectomy is removed, shave from the lumpectomy cavity are taken separately and sent separately to pathology to be reported for margin positivity. Now, talking about mastectomy, which is the other surgical treatment. Mastectomy consists of removal of, and I highlight almost all the breast tissue, because I always mention to patient, it is impossible to remove 100% of breast cells. There is a misconception that having a mastectomy will eliminate the chances of developing breast cancer or having a recurrence. So there will be always microscopic cells behind the skin. So that's what I always mention, that is almost all breast tissue that is removed. And there are multiple types of mastectomies. There is the simple mastectomy, which preserves the skin where the nipple is removed. There is the modified radical mastectomy, which includes removing the breast and the axillary lymph node dissection, and the nipple-sparing mastectomies, which is the one that preserves the skin, the nipple, and only remove the tissue underneath the skin. Mastectomies can be followed by reconstruction or with no reconstruction. In those women with no reconstruction, they will have a flat chest. And in those that elect to have reconstruction, they can have tissue-based or autologous reconstruction, where tissue from the abdomen, from the gluteus can be used for to fulfill the area, the missing area in the breast, or the implant-based reconstruction. For the nipple-sparing mastectomy, I also wanted to mention that this is an oncological safe procedure. It's important to keep in mind the distance from the nipple to the cancer, the skin quality, the tumor size, and this can be offered also for BRCA mutation carriers. Now, I just wanted to mention about the use of contralateral prophylactic mastectomy, also known as double mastectomy. This consists of removing the unaffected breast or the healthy breast for reasons that are not entirely understood. The national rates of contralateral prophylactic mastectomy have tripled in the past decade across all the ages. And we know that there is no oncologic survival benefit, and there is an increased risk of surgical complication, need for additional intervention, more time in the operating room. However, some women report choosing a contralateral prophylactic mastectomy for reduced surveillance, improved symmetry, and peace of mind. It is always important to highlight that we should not treat anxiety with the knife. Those women have to understand that they are not gaining any benefit and they're having more risk. This is not applicable for those genetic mutation carriers. This is different from the prophylactic mastectomy, which is the one recommended for those with a significantly high risk of developing breast cancer in the future. In terms of the contralateral prophylactic mastectomy, the American Society of Breast Surgeons released a statement where they say that contralateral prophylactic mastectomy should be discouraged for an average risk women with unilateral breast cancer. However, patients' values, goals, and preference should be included to optimize shared decision making. The final decision whether or not to proceed with a CPM is a result of the balance between benefit and risk and patient preference. And last but not least, I also wanted to mention the de-escalation in surgery in the axilla. We know the ACOSOC-C11 is a study that prospectively examined the overall survival in patients with sentinel lymph node metastases undergoing breast-conserving therapy. So basically, patients with clinically node-negative that underwent breast conservation and sentinel lymph node biopsy and were found to have 1 to 2 lymph node positive were randomized to 2 arms. One arm to proceed with the standard of care at the time of which was axillary lymph node dissection versus no further surgery. It's important to highlight that these patients received breast radiation therapy and systemic adjuvant therapy. And again, in the follow-up among those patients with small cancers, no palpable axillary adenopathy, and 1 or 2 sentinel lymph node biopsies, there was no difference in overall survival, and there was no need for proceeding with further axillary dissection. So the take-home points included in here, we know we have de-escalating surgery for the breast, we have de-escalating surgery for the lymph nodes. We have de-escalate in radiation therapy for women after 70, and also de-escalate from systemic therapy. However, it's very important to highlight that this is applicable for a specific type of patients and subtype of tumor, and I will be happy to take any questions.
Thank you, Monica. What a wonderful talk. There were so many great and interesting points that you made, and we're going to save our questions for the end. I'll collect questions from the Q&A as we go along, and then we'll can address them all as a group at the end. But what a wonderful talk. Thank you. Our next speaker is Dr. Kevin Dew. He joined the Yale Cancer Center and Smilow Cancer Hospital from NYU Langone Health in 2021. He's an associate professor of radiation oncology and a director of the residency program in radiation oncology. He received his medical degree from the University of Pennsylvania School of Medicine and his PhD in cellular and molecular biology from there as well. He has a master's degree in clinical investigation from New York University School of Medicine, and he's led numerous clinical trials while he was at NYU. And we're so excited when he joined our team. And tonight he's going to talk about radiation therapy for early stage breast cancer.
Well, thank you so much for the kind introduction,
Dr. Lynch. And after listing all my overeducation, I'm going to be embarrassed by having difficulty navigating Zoom right now. And I presume you're seeing, here we go. So finally figured that out. I have to say I'm humbled by following Dr. Valero. I think is very clear here, and I'll echo what Dr. Lynch said. It's always incredible, really getting to learn from my colleagues, and we really have surgeons here that have a really incredible perspective. Not just on the technical aspects of surgery, but the full picture of taking care of our breast cancer patients. And I'm also going to say that I'm very gratified to see on the participant list and the guest list tonight many of our patients here, and it's really great to see your names on the list there. Welcome. So I'm going to be talking about radiation therapy for early stage breast cancer. And as Dr. Lynch said, I'm associate professor in the Yale School of Medicine here in the Department of Therapeutic Radiology, and the medical director of the Trumbull Radiation Oncology Center here at Park Avenue, working together with this really amazing team of breast cancer doctors. And I think the word multidisciplinary has been thrown around a lot, and that's actually, one of the most gratifying things. I was just thinking just before logging on how much I'm actually looking forward to this evening and being together with all my colleagues on this call, just like we are every day talking about our patients. And it really is this incredible mix of I'm sorry, I'm trying to use a pointer, but I can't, so I'll just describe of medical oncology, the chemotherapy doctors, the surgeons, and radiation, and of course all of you, the patients. And I think, a lot of times for those who don't know me on the participant list, on the guest list, of course, radiation oncology, radiation treatments are probably the thing that people are most kind of think about as more of a mystery than the other aspects of cancer care. And so, I thought I would talk a little bit tonight about radiation oncology and then just some of the advances that we've had in recent years in order to try to improve patient care, maintaining or improving cure rates while decreasing the side effects of radiation. So if you'll indulge me a little bit of a history lesson, and this may speak to a little bit of overeducation on my part, but it is important, I think, and kind of a little bit of a radiation trivia, that we've been using radiation for medical reasons for over 100 years. And this is a picture of Willem Röntgen, who discovered these mysterious, quote unquote, X-rays. Didn't really understand what was going on, but this is the first diagnostic radiograph of his wife's hand with the wedding band that you can see in that dark area on the ring finger. And that was the very first event where you could actually see into a person, make a diagnosis without surgery, without cutting open a patient. Very powerful and changing, world changing. Marie and Pierre Curie, a husband and wife team, almost immediately started compounding and discovering radioactive isotopes. And just as a nice other piece of trivia, Marie Curie, the first woman to win not just one Nobel Prize, but actually 2 Nobel Prizes in chemistry and physics, and really an incredible woman. And almost immediately after the discovery of radiation, they were using this to treat cancer patients. And the first cancer patient to be treated with radiation in Chicago was actually a breast cancer patient. So over 100 years of treating patients with radiation, breast cancer patients with radiation. And then there was in the 1930s to 1950s, the first chemotherapy started coming about. And then in the 1950s, the workhorse that we use today, called a linear accelerator, kind of the precursor or the first generation of the modern radiation machines that we use to treat patients, came about. Really an incredible engineering feat. And very quickly afterwards, combination chemotherapy and radiation offering the first real cures for cancer in the 1950s in the first cases of lymphoma. And subsequent years opening up decades of a golden age of using chemotherapy, radiation, and surgery, really in very intelligent combinations in order to treat cancer and increase the cure rates dramatically over those years. So modern radiation therapy, as we know it, is really an incredible combination of all that we know in physics, a lot of what we know in biology, and really huge advances in technology and engineering, all to really provide personalized patient care. We customize a radiation plan for everyone, not just in terms of where we're aiming or what dose of radiation we're giving, but really what I do is try to really take into account patients' preferences, what's important for them, what their goals are in their cancer care, discussions with my colleagues, the surgeons, the medical oncologists, all in integrating these to really be in a very measured way, personalizing again the radiation treatment, tailoring it around all these different very important discussions. So why do we use radiation? As Dr. Valero had nicely said, we use it in order to, in many cases, to reduce the risk of the cancer coming back after successful surgery. And we use it as part of breast conservation therapy. And so as Dr. Valero was saying, many years ago, the standard surgery was a total mastectomy, as seen on the right side here. And what radiation does is it really allows surgeons to do smaller surgeries, partial mastectomies or lumpectomies, as they're called. And then we essentially treat the remaining breast tissue with radiation, really kind of covering the breast tissue that would have been removed during a total mastectomy, achieving the same cure rates, but preserving patients' breasts and improving quality of life. And this is how we give radiation treatment. This is, again, kind of a drawing on the left side of a linear accelerator. The head of the gantry is away from the patient. The patient is laying there on the treatment table, and we aim radiation at the patient and treat the breast tissue. And you can see that, the radiation dose distribution, you can see that wash of color across that CT scan on the right side. And as you can, for those who haven't seen a CT scan, this is kind of a cross-section bread loaf looking from the feet up toward the head of the patient laying there on the table. And kind of at the top of the picture is the front part of the patient. The middle, the black areas are the lungs, and the back area are the ribs and the spine. And you can see that the color wash is how we aim the radiation at the patient's breast tissue. And you can see that it's very deliberate how we aim. The edges are very sharp. We're covering the breast tissue, but really, for example, the heart is well away from the radiation field. And we can even shape our radiation fields with this linear accelerator, and in the head of the gantry where the beam is coming out on the left side, that you can see that picture. If you look at the bottom right, and I apologize, no pointer, you can see these metal leaves that all individually move in and out of the radiation field to shape the radiation field. We can block out normal tissue while aiming radiation where we need to aim it. And so otherwise, we can also use various techniques that are really much newer and very dependent on things that are, in one sense, very simple conceptually, but the same sense, require a lot of newer technology and engineering and computing power in order to execute properly. And one thing, for example, that we can do is very simple. You can see that, for example, in this patient, looking again at the CT scan on the left, that if we were to treat the breast tissue, that the heart actually would is right up against the breast, the chest wall, and part of the heart would get exposed to radiation treatment, which we want to spare the heart and spare the patient heart side effects from radiation. We can use a technique called deep inspiratory breath hold, or DIBH for short. And when you take a breath, as seen on the right side, you can actually see that the chest wall moves out and forward away from the heart. And now you can see that there's actually some lungs, some black space between the heart and the breast. And so we can actually then aim radiation at the breast and avoid the heart. And so this is a very important technique that we use routinely in order to reduce probably the most significant, medically significant risk of treating breast cancer, which is heart exposure to radiation. The other thing that we can do to try to avoid heart exposure and lung exposure is actually very conceptually simple again, which is treating the patient not laying down on their back, but laying on their front. And in this case, in the top left, right, you can see top left upper, top left, I should just say, apologize, that you can see, again, this kind of color wash of the radiation across the breast. But you can see that right below that on the left side, if a patient has a larger amount of a larger breast, that as we try to aim radiation at this larger area, we actually capture more lung tissue, and there's actually even a risk of capturing more heart as well. And so patients with larger breasts, we may actually have difficulty reducing heart and lung dose in some patients. And so positioning patients can be important. And so, for example, if we just position a patient on their front side, you can see in the lower right panel that we can actually entirely avoid exposing the lung to radiation. There's a trade-off. The heart, as you can see, it perhaps falls forward. So there's none of that black space of the lung there between the heart and the breast. And so, this is very patient dependent in terms of the anatomy and whether it works and helps. And then finally, and this is really something which is very new relatively in breast radiation oncology, but still something which we offer, not uncommonly to patients, is in very favorable patients where there's, patients have very small tumors, favorable biology, and favorable anatomy, that we can even maybe perhaps not treat the whole breast, but only treat in the highest risk area of recurrence around where the tumor was, something called partial breast radiation. And you can see here that that really we can avoid entirely heart and lung dose while treating only a very small amount of breast tissue. Again, something that's not for everybody, but something which is an option, and it works for some selected patients. And then finally, a word about radiation therapy scheduling and how much radiation we give patients. And traditionally, we used to give radiation over 6 to 7 weeks of daily radiation, very long courses of radiation. Now at Yale, our standard is 4 weeks of daily radiation, still quite a lot of visits, but not as long as 7 weeks. So certainly improving. And then coming in the next few years, certainly, I think it'll become more and more common. And certainly this is also an option for our patients, again, selected patients here at Yale, is that we're really moving toward 1 week of radiation, very short courses of radiation. And that, of course, is very convenient for patients, and as many of these cancer treatments are very time consuming. And I'm sure many people have of course, better things to do. So it is one of these things where we are trying to move radiation toward more convenient, patient-centric regimens, and to again make sure that they're less intrusive and not compromising on quality of care here. So in summary, one size does not fit all. And that's really how I like to think about radiation treatment, that, when you're talking about radiation, it's not just having a patient come in and aiming radiation and not really having any consideration for the patient, what their priorities are, or doing it in a unmeasured way. But it is about taking into account all these considerations between chemotherapy doctors, surgeons, the patient, radiation, and tailoring a total treatment based on the patient's specific cancer characteristics and patient priorities. So thank you very much. I'll turn this over back to Dr. Lynch.
Thank you, Dr. Du. What a great talk. And, it really is just so important that we continue to recognize the kind of the role of the multidisciplinary team. Am I frozen?
Oh, you're coming through clearly.
Okay, got it. And the value of the multidisciplinary team, especially as we all work together to provide the best care to patients. So our next speaker will be Dr. Kathleen Fenn, who is an instructor in clinical medicine and medical oncology. She received her medical degree from Yale School of Medicine and completed her internship and residency at Columbia. She is a member of the T32 Cancer Biology Training Program, and her research focuses on the tumor immune microenvironment in early stage hormone receptor positive and HER2 positive breast cancers. And Dr. Fenn is going to talk about the use of immunotherapy in breast cancer medical oncology.
Great. Thank you for that kind introduction, Dr. Lynch. And I want to reiterate just what a pleasure it is to work with such wonderful specialists as a multidisciplinary team here in the Bridgeport, Trumbull, Fairfield area, clinicians who are not only leaders in the area, but often cases leaders on the national stage. And it's just a pleasure to work with you all. Today, we've been tasked to talk about some innovations in medical oncology as doctors who prescribe medications for the treatment of breast cancer. Many of you will be familiar with drugs like chemotherapy or anti-hormonal therapy, but myself and Dr. Fischbach have been tasked with talking about some of the newer agents and strategies that are out there to treat breast cancer in innovative ways. To deliver patients better outcomes. And so I'm going to touch on immunotherapy and what is its role in breast cancer, if any, and where are we going in the future. Of course, not a topic that can be fully addressed in 10 minutes, but I'll try to give the bird's eye view. So what is immunotherapy, or what are we talking about? So we know that the human immune system on a basic level defends the body against threats like bacteria, viruses, fungi. And after the physical barriers of your skin and the GI tract, the main line of defense are these white blood cells that search for and attack microorganisms, prevent infection, and take out abnormal cells. We know that actually many cancers are prevented by our immune system and its surveillance, but we also know that cancer can outsmart the immune system and develop methods to evade it. And so while our traditional kind of methods like chemotherapy and targeted therapy directly affect the growth and proliferation of cancer cells, when I'm talking about immunotherapy in this talk, I'm talking about medications that can actually harness the immune system to recognize and destroy cancer cells and deliver more effective treatments through those means. When we talk about immunotherapy, the immunotherapy drugs that are most commonly or most prevalently employed in practice are, and what you may be most familiar with, are the immune checkpoint inhibitors. And so we know that in our body, there are white blood cells called T cells that are tasked with circulating and identifying agents that are foreign to the body and tagging them essentially for destruction. But through that process, these cells need a mechanism to recognize what is normal and shouldn't be destroyed. And that one of those ways is through the immune checkpoints. And so these T cells will express a protein called PD-1, and when it interacts with another protein called PD-L1 on normal tissue, it is kind of a blocking signal that tells the T cell to, move on and not attack, what they're interacting with. Tumor cells, however, can use this and employ this method to put a brake on the immune system and stop the immune system from attacking the tumor. And so the immune checkpoint inhibitors that are on the market, the basic premise is to block this checkpoint to allow the T cells, the immune system, to then progress and target the tumor cells for death, to eliminate a brake on the immune system, so to speak. And so among these agents include, what we'll talk about in a moment, pembrolizumab, which is marketed as Keytruda, nivolumab, which is marketed as Opdivo, et cetera. So where do these drugs, have a role, if any, in breast cancer? So, we do know, unfortunately, most breast cancers, including those which are hormone receptor positive or overexpress the protein called HER2, they're considered immunologically cold and not sensitive to the currently available immune checkpoint inhibitors on their own. There is, however, a subset of breast cancer called triple negative breast cancer that does not express hormone receptors or does not express the HER2 protein that actually has shown to be a very good target for immunotherapy. These tumors tend to have a higher level of that PD-L1 expression and a higher average concentration of immune cells in the tumor. Triple negative breast cancer accounts for approximately 15% of breast cancers and is associated with a more aggressive course. And up until recently, our main tools were pretty blunt in terms of our treatment, and the mainstay has been chemotherapy. But we have desperately needed more advanced therapies to add to chemotherapy to be able to deliver patients better outcomes and more cures. So in early studies of immunotherapy, which again has really changed other tumor types, the treatment of other tumor types like lung cancer and melanoma, in early studies, there was activity in triple negative breast cancer. And this was first looked at in metastatic triple negative breast cancer. These are patients who unfortunately do not have disease that can be cured by surgery, but can be treated with the intent to control the disease and prolong survival. So one large randomized study where patients were randomly assigned to receive chemotherapy or chemotherapy with pembrolizumab. Patients who did receive the immune checkpoint inhibitor pembrolizumab on average lived longer than those who did not receive the immune checkpoint inhibitor, showing benefit, for adding this agent to chemotherapy in advanced triple negative breast cancer. Patients who benefited the most were those who had higher levels of that PD-L1 protein expressed on the tumor. And now this agent, pembrolizumab Keytruda, is approved for the use with chemotherapy in advanced triple negative breast cancer for that subset of patients that express its higher levels of PD-L1. seeing the activity in advanced triple negative breast cancer, then immunotherapy has been studied in earlier stage breast cancer, where the goal is to cure the patient with a combination of chemotherapy, other treatments, surgery, plus or minus radiation. So the standard of care for most triple negative breast cancers is to give chemotherapy prior to surgery. We know that patients who have a complete response to chemotherapy after receiving it prior to surgery have improved outcomes long-term. So in another randomized study where patients were randomly assigned to receive chemotherapy or chemotherapy with pembrolizumab prior to surgery, adding pembrolizumab significantly improved the chance of having a complete response to treatment, and later on was shown to significantly improve the chance of living without a breast cancer recurrence. And so this has really revolutionized our treatment of early stage triple negative breast cancer. And pembrolizumab is FDA approved now for what we consider high risk early stage triple negative breast cancer, for those whose tumor sizes are 2 centimeters or greater, or those that have lymph nodes that are involved with cancer. Of course, no treatment is without side effects. While these immune checkpoint inhibitors do not carry the same side effects you think about with chemotherapy, most do not, in the most cases, you won't have hair loss, blood count issues, nausea, or vomiting. There are certain risks, and those are primarily related to the risk of activating the immune system against normal tissue. And so, while only a small subset of patients will have very severe side effects, around 30 to 50% may have mild side effects. Some of the most common are inflammation in the thyroid gland, which often can be managed with thyroid medication. And then we can see inflammation elsewhere in the body, including in the lungs, abdomen, colon, skin. And so it's important for anyone who's on an immune checkpoint inhibitor to report any side effect to their treating clinician to ensure that we are ruling out or making sure we're identifying any side effects that could be related to immunotherapy. Symptoms, when they're severe, can be treated with steroids or other immune suppressive medications. So we discussed that immunotherapy really has changed considerably the treatment of triple negative breast cancer. But we are hopeful that in the future, immunotherapy strategies can benefit a wider subset of patients with breast cancer. And so there are various research strategies that are actively being studied in all subtypes of breast cancer, including in other cancers. And I'm just, as an example, of course, there's interest in cancer vaccines. Vaccines that can identify specific aspects of a tumor and target those cells for, target the immune system to recognize and destroy those cancer cells. There's research in adoptive cell therapy, which is a process of actually taking immune cells from the body and engineering them to be more effective at targeting a tumor and then reinfusing them in the body to target disease. There's other immune checkpoints and proteins that activate the immune system. That there are other drugs in development to either activate or eliminate those checkpoints to enhance immune attacking of tumors. And then finally, there's interest in modifying actual live viruses to target and infect cancer cells to promote killing tumor cells. So while I will emphasize none of these strategies are currently approved or have been proven in a rigorous way to be effective, they're all underway in various clinical trials nationwide. So takeaway points include that we know that immunotherapy, the really main point is to try to activate this immune system to attack and destroy cancer cells. That pembrolizumab, branded as Keytruda, when it's combined with chemotherapy, improves outcomes in both high-risk early-stage triple-negative breast cancer and in a subset of patients with advanced triple-negative breast cancer. Unfortunately, these drugs are not effective on their own in other subtypes of breast cancer and are not approved in that setting, but we are hopeful that as research accelerates in this field, that immunotherapy approaches will benefit more and more of our patients. And you may always ask your medical oncologist about what might be applicable in your case. Thanks very much. I'll stop sharing.
Dr. Fenn, what a great talk. And we're all excited about the opportunities for improving care for women with triple negative breast cancer. So the more that we can learn and talk about these medications and integrate them into practice, we know will make a difference for our patients. So thank you. And last but not least, always a crowd favorite, Dr. Neal Fischbach, who is a medical oncologist in the Smilow Cancer Hospital Care Center in Trumbull. He has been kind of the foundation and heart of this program for quite some time, and we're all glad to be on his team. He attended the University of Pennsylvania and then Harvard Medical School, completed his fellowship at the University of California in San Francisco, and is a medical oncologist here in Trumbull. He is also the assistant medical director to the clinical trials office for the care centers, and he coordinates clinical trials across Yale's network. And so, Dr. Fischbach, I will turn it over to you for your talk on innovations in medical oncology.
Well, Melanie, thank you so much for that introduction. I'm so happy to be with the esteemed panel and to welcome Monica, and relatively recently, Kathleen and Kevin as well, to our really amazing breast team. I'm sorry for the echo in the room I am in. I'll try and talk close to the microphone. Well, Kathleen and I, when we were thinking about the medical developments over the last years for breast cancer, thought we would make it more mechanistic than specific drug related. So Kathleen took care of the immune therapy, and I was going to spend some time talking about antibody drug conjugates. And while Kathleen had pointed out that adoptive cellular therapy, taking immune cells from one person in yourself and putting them into somebody to fight cancers, still a bit on the horizon for breast cancer. Adoptive antibody therapy, where we take antibodies, which are usually bacterial virus fighting proteins, and put them into the body, have actually been around for breast cancer for quite some time. So I'm going to share my screen. And if I'm allowed to share my screen, and now I'm the only person who's having a technical difficulty. Entire screen. Okay, share, not sharing. I'm going to try that again. My apologies. Oh my goodness. Entire screen. Melanie, I'm going to apologize. I'm going to, I think I might have to log out of this version, my web version, because it is not letting me share. I'm going to try this one more time.
Do you want to email the PowerPoint to Renee? And she could show it. We could do some questions while you do
I think I was able to log in through this web page, so I'm going to try one more time to join this way. Okay. So hopefully that will work. I'm going to get rid of this.
Success.
Look at that. I can do tech.
Yay.
Sorry for the delay, guys. And so good to see some familiar faces on the share. So again, I'm going to be speaking a little bit about antibody drug conjugates. And the first obvious question is, well, what's an antibody? Antibodies are remarkable proteins that our body makes to fight generally infections. And our body can make an infinite number of antibodies to fight off an infinite array of infections. And a also semi-miraculous thing is it turns out that cancers can express things on their surface we call antigens, which these antibodies, our own body's usually infection-fighting tools, can recognize as foreign and get rid of. And the business end of the antibody is right here at what's called the antigen binding site. This is the part of the antibody that binds to something from a bacteria or a virus or a virally infected cell. And then the effector part of the antibody is right here. And this part of the antibody can do things like attract immune cells to the area to kill virally infected cells, or it can mark bacteria that are bound to the antibody to be cleared from the circulation by our body's sanitation system, if you will. And this is how our immune system generally works for infection. So we might encounter a virus and our body will make antibodies against a specific part of that virus. Again, what's called the antigen or epitope. And once the virus or a cell that's infected with the virus, and you can even think of this as a cancer cell, that expresses these abnormal targets on its surface, once the cell or cancer cell is coated with these antibodies, a variety of really good things can happen. The coated cell can be lysed or killed by the immune cells. The antibody can tell the virus to stop replicating, or it can bind to elements on the cell surface that prevent it from spreading to other cells. So it was really about 30 years ago that some very smart people figured, well, can we take advantage of this for cancer cells? And the very first target that was developed in a human cancer was the HER2 receptor, which we recognized was abnormally overly abundant in about 1/5 of breast cancers. And the breakthrough and genius in this project was developing antibodies against this receptor that you could give to people that people didn't immediately reject or cause allergic reactions. And so while in a HER2 overexpressing cancer cells, the too much signaling through this receptor causes cells to grow and divide faster, this actually turns out to be the Achilles heel of HER2 overexpressing cells. So this first antibody, which is developed, trastuzumab, brand name is Herceptin, was tested and first FDA approved in 1998. So again, this was the first antibody FDA approved to treat a solid tumor in humans. And lo and behold, when you give this antibody to people with HER2 overabundant breast cancer, the antibody binds to the cells, and not only does the antibody itself cause the cells to slow down and can kill them, but it makes the cells exquisitely sensitive to chemotherapy. I like to tell people it's like kryptonite for the cancer cells. Once you drape this antibody on the surface of the cancer cells, they became even really susceptible even to low-dose chemotherapy. And the way that cancer science progresses is once we hit upon a good idea in patients who have advanced or incurable breast cancer, we think about taking the next step. Well, okay, if this is a breakthrough for people with metastatic breast cancer, might it also help us cure more people with early breast cancer? And in fact, that was the case. When added to chemotherapy, there was a dramatic doubling of cure rates of women with early HER2 positive breast cancer. And HER2 positive breast cancer went in one instant from being the highest risk subset of breast cancer to being the most highly curable set of breast cancer. So in 2006, Herceptin was FDA approved to treat women with early HER2 positive breast cancer to improve the cure rate. And since then, there have been a series of follow-ons, and now we are using Herceptin, this medicine originally developed for HER2 overexpressing breast cancer, for a variety of other solid tumor types, most notably gastric cancer, endometrial cancer, that may also have too much of the HER2 receptor. Well, so where does that get us to updated antibody drug conjugates? So we're all probably familiar with the Trojan horse mythology from Greece, that Odysseus and a few of his buddies hid inside the belly of the Trojan horse, were allowed into Troy, and were able to open the security grates, and the Greeks triumphed in Troy. Well, antibody drug conjugates are actually quite similar. And the paradigm for the antibody drug conjugate is a medicine that was first developed for breast cancer called Kadcyla. And Kadcyla is nothing more than Herceptin, trastuzumab, and stuck to that antibody are a few chemotherapy molecules. And the real $1 million magic for any of us who invested early in this technology, and none of us did, is this linker here, that these chemotherapy toxins, this is actually a molecule that's far too toxic to give to human beings, but it's linked to the antibody via this special linker that only releases the chemotherapy when the antibody is inside the cell. So this is like a Trojan horse. The antibody brings the chemotherapy to the cell here. This is the Kadcyla antibody binding to the surface of the cancer cell. This antibody with toxin is taken up by the cancer cell, and inside the cell, in what's called the lysosome, the linker is cleaved and the toxin is released and the cancer cell is destroyed. And Eureka, this really worked phenomenally well. Not only was it more effective than chemotherapy in women who had received prior treatment for metastatic breast cancer, but it was dramatically less toxic than typical chemotherapy, because if you think about it, the chemotherapy was only going to the cancer cells and not going to the healthy cells. And of course, that's an oversimplification. Kadcyla does have some side effects, but significant side effects, but compared to chemotherapy, substantially gentler. And in the exact same paradigm as for Herceptin with breast cancer, once Kadcyla was approved for metastatic breast cancer, it was investigated and validated in early HER2 positive breast cancer. And we found we are able to dramatically improve the cure rate of early HER2 positive breast cancer that may not be completely eradicated by preoperative chemotherapy. And so this medicine, Kadcyla, overnight, not only changed how we think about treating early HER2 positive breast cancer, but it changed the whole order in which we do treatment. And we went from a time period where everybody got surgery first, and then they got chemo, and then they would get radiation and anti-estrogen therapy if they need it, to a time point now with HER2 positive breast cancer, the vast majority of people would get chemotherapy first, so we could assess if they were a candidate for this really important medicine, Kadcyla. And the next step in antibody drug conjugates is really something that was reported this year at our big cancer meeting. In one of the two standing ovations, I hate to reveal my age, but in over 20 years of going to our annual cancer meetings, I've only been part of two standing ovations. And the first standing ovation was when Herceptin was first reported to improve the cure rate of women with HER2 positive breast cancer, double the cure rate. And the second was just this last year, when the results of a new medicine called Enhertu were demonstrated to dramatically improve the outcome of women with metastatic breast cancer that not only expressed this target, HER2, in a large quantity, but might express this target in a small amount, a much bigger population of women with breast cancer. So these first generation antibody drug conjugates like Kadcyla required that the cancer cell have a high target expression, lots of HER2 on the surface, and all of the cancer cells needed to express that target if the drug was going to work. And this next generation actually allows for, you can actually have a very low target expression level. And that's because the payload, the toxin that we're putting on these antibodies is both more potent, but we're able to load more of it onto the antibody. And maybe most importantly, not all the cancer cells need to have any target on the surface, that there can be some bystander effect. And that's the HER2, which I think is really a paradigm for our next generation of antibody drug conjugates. So this is an antibody like Herceptin and like Kadcyla that's directed against HER2, but it carries this payload that's significantly more effective than the payload on Kadcyla. And moreover, there are more payload molecules per antibody. And like Kadcyla, these toxins are only released inside the cells, but there is a critical difference. And the critical difference is that these toxins can leak out of the cells and treat bystanders. So here's the HER2 receptor. It gets into the cell, the toxin is cleaved, but then the toxin can leak out of the cancer cell into the nearby cancer cells. So this opens up the opportunity for 20% of breast cancer has a lot of HER2 on the surface, but about 60 to 80% of breast cancer has a little bit of HER2 on the surface. And so overnight, we have developed a drug where that is applicable to a much, much larger population of women. And at this last ASCO meeting, they reported the data from this Destiny-04 trial where women who had metastatic breast cancer that was not HER2 overexpressing, they just had to have a little bit of HER2 on their surface. And they were randomly assigned this HER2 drug or whatever the doc thought was going to be the next best therapy. And that was dramatically better. It more than doubled the length of time that women were living and living well. And as a result of that, HER2 has been FDA approved for women with with metastatic breast cancer that expresses just a little bit of HER2, and it's changing the whole way that we measure, think about, and report what's HER2 positive, what's truly HER2 negative, what's HER2 low. And on a very similar theme, there is a related antibody drug conjugate called sacituzumab, and I think I might even have talked about this at our last Smilow shares, because sacituzumab had just been approved for use in triple-negative breast cancer. But the target that this drug Trodelvy binds to actually is ubiquitous. It is expressed across the whole spectrum of breast cancer and in many other solid tumors, in fact. And just this year, results were reported with Trodelvy used in the largest population of women with metastatic breast cancer, women with estrogen receptor positive metastatic breast cancer. Trodelvy was also very effective in that population of people who had been through anti-estrogen therapy, had been through chemotherapy, and had limited therapeutic options. Trodelvy now, together with HER2, has markedly expanded the population of women who are candidates for antibody drug conjugates in both metastatic and hopefully soon early negative breast cancer. And I can't end without a plug for our Yale clinical trials. We early next month are going to open a clinical trial that's using a next generation HER2. It's called datopotamab deruxtecan, and it's going to be investigated in women with triple negative breast cancer as first-line therapy. And we have another study with HER2, and as we had talked about, the natural progression of medicines going from the metastatic setting to the early curative setting. And we are going to participate in a trial that's going to investigate HER2 given before surgery compared to the conventional chemotherapy we do. And in terms of the estrogen receptor positive, HER2 negative, the HER2 stuff is just still too new. This year at ASCO, and we are now designing the next generation clinical trials. So thank you all for your attention. I'll stop sharing. And again, thanks for joining tonight.
Neal, what a great talk. Thank you. This is such exciting progress. And we're so glad that Yale is part of these cutting edge clinical trials. And that's due to your leadership. So we have some questions from attendees. And we'll start with a question that was for a series of questions for Dr. Valero about axillary surgery. The first question was about, how do you estimate the recurrence risk for patients who would have 6 out of 10 axillary lymph nodes that were positive? And how does that, as we move away from doing more and more axillary dissections, how does that affect our ability to estimate recurrence risk for patients?
Great question. We know that cancer treatment and cancer prognosis and recurrence nowadays is being determined by the subtype more than for like the number of lymph nodes. At this point, we know that, the hormone positive, HER2 negative is the most common type of cancer. This is usually the one that has, less chances of recurrence, even if you have disease under the arm, in the axilla. The only information that we know when we have involvement of the lymph nodes is to know like the disease have moved from the breast to outside and has reached the armpit. Therefore, it has a potential risk to move outside to other part of the bodies, but it doesn't mean like it has happened. So that's why certain like systemic therapy at that point is the most important part. So we know like, the more lymph nodes you have involved, most likely more chances for the disease to get out of the breast that the patient had. But there is not a way to say like, if in this case, like it's more tailored to subtypes of cancer and more tailored based on that type of information. So in short, yes, when you have lymph nodes involvement, there is more risk for the disease to have escaped the breast, but it doesn't determine that it's going to happen or that recurrence will happen, because systemic therapy at this point is more important than any surgical intervention.
Oh, that was a perfect answer. Yes. There's a question about the use of Faslodex for stage 4 breast cancer. Dr. Fenn, Dr. Fischbach, do one of you want to comment on that?
I'm not sure if there was a particular kind of inquiry about when we use Faslodex. Certainly Faslodex is in our armamentarium for patients who have metastatic hormone receptor positive breast cancer. It's especially effective in cancer that may have progressed or learned to grow despite the use of oral medications like aromatase inhibitors, anastrozole, Arimidex, those types of medications. As we're talking about innovations, it's I think worth mentioning that there are newer drugs under development with the same or similar mechanism as Faslodex that are in oral form, in pill form. And we're really excited about these as a potential option in the future, because we know that our patients often suffer with the injectable, form of Faslodex. It can be painful and uncomfortable. I don't know if Dr. Fischbach has additional insight.
No, I think, Kev, I think you covered the points exactly right. Faslodex has a unique mechanism of action. It eliminates the estrogen receptor as opposed to just blocking it. And it's just unfortunate we've had to give it as an injection all these years, and really looking forward to the orals when they're available.
Thank you. There's a question for Dr. Du. Can you talk a little bit about hypofractionated radiation therapy after lumpectomy?
Sure, of course. So I think as we move towards shorter treatments, and just the definition of hypofractionated to just make sure everyone's on the same page, we think about what we used to do as very small doses of radiation over, again, 6 to 7 weeks of daily radiation treatment, but each dose, what we call conventionally fractionated. And that's arbitrarily, a certain amount of radiation, about what we called 2 gray, gray being the dose that we use, and gray is like centimeter or inches, it's just a measure of radiation. So anything more than 2 gray, we call hypofractionated. And how we've been able to shorten courses of radiation is by giving bigger shots of radiation each day. And that's really because of advances in technology and our ability to shape and again, make kind of smooth out the radiation dose. And so when we're talking about accelerated courses of radiation, faster courses of radiation, we're giving more radiation each day. And that's the concept of hypofractionation. Historically, we actually used to think that giving more radiation each day than a conventionally fractionated dose, giving hypofractionation, would actually lead to potentially more scarring, potentially more side effects in the long term. And that's where, the advances in technology and how we give radiation have really enabled us to give radiation more safely and to avoid some of these issues that we think about with giving bigger shots of radiation. The interesting thing is that the most recent trials are even suggesting that the cosmetic outcomes and the quality of life outcomes with hypofractionated radiation may actually be better than conventionally fractionated radiation. And especially as we refine our techniques and we kind of, I think as all these clinical trials that Dr. Fischbach, Dr. Fenn are talking about with the drugs, we're also refining our techniques in radiation with clinical trials and figuring out what techniques are the best for delivering hypofractionated radiation. And the most recent things, I think, we're sorting out again what the best way is of giving radiation faster and more conveniently. But again, it's something that we think at this point is certainly safe, and that the cosmetic and quality of life outcomes are equivalent, if not better.
Thank you. We have a question about immunotherapy. There is a general question about inflammation and recurrence of breast cancer, and another question about patients who have autoimmune disease like Graves' disease or vitiligo. Are they candidates for immune therapy?
So good questions, both. In terms of inflammation and breast cancer recurrence, I think that's a difficult question to answer in specifics, but we do know that there is a complex interplay between environment, your body's immune system, and other factors, including the risk that you had at the time of your first diagnosis, that all contribute to breast cancer recurrence risk. I think as our science catches up, we will have maybe learn more about predicting risk and understanding immune factors that contribute to risk, and maybe even then find interventions to hijack or manipulate the immune system earlier on in the breast cancer course to prevent recurrence. I think in the question about autoimmune conditions and eligibility for immunotherapy is an interesting one, and one that we encounter often. Of course, specifics really should be discussed with your medical oncologist who knows you the best. But I think it's a spectrum of autoimmune disorders, right? Some are quite mild and some are more severe, some are well controlled and some are less well controlled, and some would be more threatening to your health than others if they were to become poorly controlled on immunotherapy. So just having an autoimmune condition in general is not a reason, not a firm reason to not be eligible for immunotherapy, but it's a nuanced discussion between your medical oncologist and yourself regarding the risks and the benefits, and then even involving whoever else might be treating you for that autoimmune condition to confirm that it might be safe to proceed with immunotherapy if indicated.
That's a great answer. We have time for one more question. This is directed to Dr. Fischbach. Do you think there'll be some time in the future when patients with HER2 positive breast cancer are treated with HER2 directed therapies alone without additional chemotherapy?
Absolutely. In fact, some of those trials have been done and demonstrate some really encouraging results. And especially in the era of antibody drug conjugates, I think that is closer than we might think. If I might just touch on the whole clinical trial, getting back to Kathleen's question. I think there's so many questions in breast cancer medicine that oncology may not be answering just because it's not the doc's priority, but it's people with cancer's priority. Does stress and being stressed out increase risk of recurrence? What's the role of inflammation? Can I use my arm that I have a sentinel lymph node biopsy? Do I have to get blood draws and blood pressures on other arms? And so I think in hopefully the near future, we're going to be trying to more actively solicit the input of people who are living the cancer experience as to what are the most important questions to you and how do we get them answered?
That's an exciting future, and these trials and innovations and how quickly we're able to bring them to our patients is one of the most exciting things about practicing medicine now. I want to thank all of you for these great presentations tonight. This has been recorded, and this will be available on the YouTube channel for the Smilow Cancer Center. And we did have a couple questions about that. And again, I'm just so proud to be part of this dynamic team. And thank you everyone for joining us tonight.
Thank you.
Good night.